The first thing you hear is the screaming. Not from inside the operating theater, not yet, but from the corridor outside it, where the next patient is waiting and can hear everything happening to the one before him. That sound, raw and uncontrolled and utterly human, is the sound of 19th century medicine doing its very best work. And you're about to walk through that door. You're in London, somewhere in the 1840s, in a teaching hospital that smells of something you will spend the rest of your life trying to forget. Damp stone and old blood and the particular sweetness of flesh that has been cut and cauterized and left to heal in rooms that have never once been properly cleaned. The walls are dark with years of absorbed matter. The wooden operating table at the center of the room is stained so deeply that no amount of scrubbing has ever returned it to its original color, and no one scrubs it between patients in any case, because no one yet understands why that would matter. The surgeons wear their operating coats with a particular pride, dark, stiff, crusty with the evidence of previous work. A clean coat on a surgeon in 1840 is the mark of an inexperienced man. The veterans wear their history on their sleeves, quite literally, and consider it a badge of competence. You're not here as a surgeon. You are the patient. You have been brought in from a street in Southwark with a leg that has gone wrong in a way that cannot be fixed by rest or poultice or prayer. The surgeon who examined you this morning spoke quickly, used words you did not fully catch, and then told you, with the brisk efficiency of a man who has said this particular sentence several hundred times, that the leg must come off. You have had perhaps 4 hours to think about what that means. You have spent at least 2 of those hours being told, by well-meaning people in the waiting corridor, exactly what you are about to experience. They were not trying to frighten you. They simply had no reason to imagine that silence would be kinder than truth. There is no anesthetic waiting for you. Not yet. Ether will not enter a British operating theater until 1846, chloroform not until 1847, and even then the adoption is uneven and contested. There are surgeons in London who will argue, well into the 1850s, that pain serves a purpose, that it keeps the patient alert, that numbing the body interferes with the natural processes of recovery. You're living in the years just before the revolution, or perhaps just at its beginning, depending on which hospital you are in and which surgeon has been assigned to your case. What you know for certain, lying on this table with your hands gripping the leather straps on either side, is that what is about to happen will happen to you while you are entirely, completely awake. The speed of the surgeon is not a boast. It is a mercy, and every man who is trained in this era knows it with an urgency that shapes his entire practice. Robert Liston, the most celebrated operating surgeon in London before the advent of anesthesia, is reported to have amputated a leg in 28 seconds. His record, if it can be called that, is something closer to a survival statistic than a performance. Every additional second a patient spends on the table without anesthesia is a second of pain so absolute that the body begins to shut down simply to escape it. Patients die of shock on the table. They die of the combined assault of blood loss and agony before the wound has even been closed. The surgeon's speed is the only painkiller available, and it is a crude one, and you are about to discover precisely how crude. For men hold you down. This is standard. Not because you're uncooperative. You have consented. You have been told what to do. You're trying with everything you have to remain still. But because the body, when it encounters pain beyond a certain threshold, stops obeying the instructions of the mind entirely. Your muscles will contract without your permission. Your back will arch off the table without your choosing it. The men holding your shoulders and your free limb and the limb to be removed are experienced in this work, and they hold you with a firm, impersonal efficiency that is neither cruel nor comforting. They're simply doing what must be done. The student observers in the tiered seats above you, there may be 300 of them in a well-attended teaching hospital demonstration, are watching with the focused attention of men who know they will be doing this themselves within a year. The surgeon's knife enters your flesh, and your body tells you something about pain that you could never have known before this moment. There's a quality to surgical pain, to the sensation of a blade moving through muscle, scraping against bone, that exists entirely outside any previous experience. It does not simply hurt. It rewrites everything. It becomes, for the duration of its existence, the only thing in the world. Patients in the pre-anesthetic era are recorded biting through their own lips, breaking their own teeth against the leather strap placed between their jaws. One account from St. Bartholomew's Hospital describes a patient who sang hymns throughout the procedure at the top of his voice, not from bravery, but because it was the only thing his mind could find to do with itself. Another account describes a man who went completely silent and still after the first cut, not from stoicism, but from a merciful dissociation that his nervous system imposed upon him without his asking for it. By the time the bone saw begins its work, and this is the detail that sits at the center of every honest account of pre-anesthetic surgery, something happens to your sense of time. The second stretch. The room, which was cold when you entered it, is now irrelevant. The student faces in the gallery above are irrelevant. The surgeon's voice, issuing calm and technical instructions to his assistants, is irrelevant. There is only the sensation and the part of your mind that is still managing to observe itself from somewhere slightly above and behind your own skull, noting with a strange detached precision that you are still here, still breathing, still, improbably, ferociously alive. 3 hours after your surgery is completed, assuming you survive the table, you'll be moved to a ward. The ward is a long room with beds placed close together, and the men in those beds are at various stages of what the surgeons of this period call the healing process. But what the nurses, paid women of no particular training who work 12-hour shifts and sleep on the ward, call more honestly the crisis. Because the cutting is only the beginning. The real killing happens in the days that follow. Hospital gangrene is the phrase used for what enters your wound in the hours after surgery. It is not a single organism. Germ theory will not be established until Pasteur's work in the 1860s, and Lister's antiseptic revolution will not reach most London hospitals until the 1870s. But a consortium of bacterial infections that find, in an open wound on a ward where the sheets are rarely changed and the instruments are rinsed at best, perfect conditions. The smell of a surgical ward in the 1840s is described in contemporary accounts as overwhelming. One medical student from Edinburgh writes in his diary that he vomited every morning for the first 2 weeks of his ward rotation, not from squeamishness about wounds, but simply from the sustained assault of the smell. Erysipelas, paemia, septicemia, the names come later, once medicine has the language to be precise, but the conditions themselves are already there, already moving from bed to bed, already making the odds of surviving a successful operation substantially worse than the odds of surviving no operation at all. The mortality rate for amputation in a London teaching hospital in the 1840s is, depending on the institution and the specific procedure, somewhere between 25 and 40%. You have a better than even chance of living through your surgery. You have something closer to a coin flip chance of living through the month. And here is the extraordinary thing. The thing that no statistic can adequately hold. People knew this. Patients on the ward knew this. Surgeons knew this. The nurses who watch patients move from post-operative recovery into the specific, recognizable decline of infection knew this. And they came back every day. The surgeons operated. The nurses dressed wounds. The patients gripped their bed frames and sweated through sheets and called out for people who were sometimes already dead. And the work continued, because the alternative was not to try, and not trying was not, for these people, a serious option. What changed? And this is where the story turns, where the dread gives way to something that deserves the word remarkable, was not a single discovery, but a collision of several. Anesthesia came first, and its arrival in British operating theaters is one of the most rapid transformations in the history of medicine. Within 2 years of ether's introduction, the screaming in the surgical corridor had stopped. Patients arrived at the table and were carried away from it without any memory of the intervening time. The surgeons, freed from the brutal tyranny of speed, could begin to be precise. Operations that had been impossible, abdominal surgery, procedures on the chest, anything requiring sustained, careful work on internal organs, became conceivable for the first time. Then came Lister. Joseph Lister, working in Glasgow and then at King's College London, read Pasteur's work on bacterial contamination, and performed the act of applied genius that would save more lives than almost any other single intervention in medical history. He began soaking his instruments in carbolic acid. He sprayed carbolic solution in the air of his operating theater. He insisted on clean hands, clean dressings, clean everything. His colleagues thought him eccentric. Some thought him dangerous. The mortality rate in his wards dropped from roughly 45% to 15%, and then kept falling. The evidence was so undeniable that it could not, even in an era of considerable medical conservatism, be ignored indefinitely. By the 1880s, antiseptic practice was becoming standard across London's hospitals, and the era of hospital gangrene, as an expected post-operative companion, was ending. The people who forged this transformation, not only Lister and the great names, but the nurses who kept working in conditions that were genuinely lethal, the surgeons who operated day after day in the knowledge that their best efforts might still kill the person beneath their hands, the patients who submitted themselves to procedures without guarantee and without anesthetic because the alternative was simply dying more slowly. These were not heroes in any romanticized sense. They were people in a brutal situation using the relentless, ingenious stubbornness that human beings have always reached for when the available options are insufficient. They endured what could not be changed, and they changed what could. And the distance between 1840 and 1880 in a London operating theater is one of the most extraordinary spans of progress in the history of human civilization. You carry something away from that room, from the stained table and the gallery of watching faces and the particular quality of light through high windows in a hospital that smells of everything honest and terrible about what it means to be a body in the world. You carry the knowledge that the comfort we move through modern medicine expecting, the absence of pain, the faith in cleanliness, the assumption that a hospital will not kill you faster than staying home, was built by people who had none of it, who walked into wards knowing what was in the air and kept walking. That inheritance is older and harder won and more extraordinary than most of us ever stop to consider. The next chapter of this story leads us somewhere equally dark and equally human, into the London slums where the sick who never made it to a hospital ward lived and died, and, against considerable odds, sometimes recovered. That one is coming soon, and it will ask you to look at survival from a very different angle. If this one stayed with you, leave it somewhere it can find someone else. History that is truly felt is the only kind worth keeping.